always helps if the microphone is on, of course.
Yeah, so it's always fantastic when you have the world champion of cartilage in the room. So Mats, I can't imagine with these kids that there is nothing happening in the tissue, because many years ago they said this is not a chondromalacia. But could you come up with anything that it could explain if you overload or even overstimulate the cartilage in this age, and while you're growing, that could explain these symptoms they get? Or do you have any idea of that? Know anything?
No, it's very difficult because I get a lot of pain patients coming to me, and some doctors have noticed that there were some cartilage injuries, and I do an arthroscopy after looking at MRI. Doesn't look bad. There's no bone marrow edema. I do the arthroscopy, and the cartilage is a little soft, but nothing more. So then you could always question. Sometimes in those occasions I do a scintigraphic examination, and scintigraphic examination is more sensitive, and some of those patients, not all of them, some you could see that even though the MRI didn't show anything, you could see that there's an increased uptake, so there's an increased metabolic activity, and when there's an increased metabolic activity, it could be pain, maybe sometimes. And why should they have this increased metabolic activity? Well, some of those patients, if you look upon them, they are dysplastic, so there are anatomical reasons that they could have pain. So a slight overload on one side could maybe be the cause of the pain. So I think this type of dysplasia is an important part of it. And many of these patients that you see, especially when you look on normal X-ray, you see these crossing signs, which is typical for dysplasia. Many of them have pain as well.
And is there anything in relation to the cartilage and the bone and the blood vessels? Could you imagine something sitting there if you overload, stimulate something you wouldn't be able to see in arthroscopy or with MRI?
Well, sometimes if you look on the MRI, you could see that there's a different attenuation of the cartilage. So the normal homogeneous color is different in the cartilage. And if you do the arthroscopy, you could see it's soft. And when it's soft, there is more load on the bone. And in the final end, the bone will react with some sort of stiffness and increased pain. But you know, there's a long way to go to know more about it. We have a PhD student looking upon neuropeptides in the subchondral bone, and I thought there were like 3 or 4 that could be of interest to study. But when she did the evaluation that no one else had done before, she found that there were more than 10,000 of them. So you see, we will have a long time until we know which is the cause of the pain.
This is very interesting, because the pain is coming from somewhere in these younger patients, but nobody tends to know where it comes from or why it starts.
Yes, I have the same question. Could it be that because you have nerve endings in the subchondral bone, could it be that you overuse it a couple of times and then the nerves signal and get oversensitive? They don't need as much stimulus anymore to fire all the time. Could that be possible?
Yeah, that's certainly one way to go, but this is very interesting. If you look upon osteoarthritis, some persons call osteoarthritis a neurological disease. And there's a very famous picture where there's a lady, she has a paralysis in her left arm and a normal right arm. And in the right normal arm, she has developed wrist osteoarthritis, but in the paralysis arm, there's no osteoarthritis at all. So there is a messenger, and the messenger needs to come certainly from the brain. And certainly there could be the same, where could you have some sort of stimulation even from the brain in that sense. But I was thinking when you talked about management physiotherapy of these patients with anterior knee pain. And there's one doctor in Malaysia, in Qatar, he's from Malaysia, he's doing studies using shockwave on the patella for these type of patients, and he claims that he have pain reducing results. So when the shockwave explanation is that it kills the synapses reaction, the interferal of the nerve signals. So if you could find means to influence this information and maybe give fake news to the brain, so we could develop some sort of painkiller that way.
Any questions?
Thank you. I have a question for Christian, or actually two questions. One, for the exercise program, did you take into consideration anything about the load on the patella, for like how deep you did the squats, or was it okay to have a high load on the patella during that phase?
So, yeah, so in the activity ladder, I mean, we thought about what kind of activities would have more patellofemoral forces going through, but on a very overall level. So we hope that the pain monitoring will sort of help them a little bit if they do these movements that will just irritate them too much. But it's not a biomechanical sort of, you can go to here or here, and because with kids, I mean, you can't control that anyway. So, yeah.
I have one more question, if that's okay. You talked about there was no deficit in the muscle strength. Did you have a baseline, or was it unilateral pain, or was it bilateral pain that you had?
So this was compared to, I mean, the deficit was compared to a control group. So you have to be careful with that, probably that expression. But they were not different from the control group. Yeah.
Okay.
And yeah, and as you say, some of them would have bilateral problems. What I can show you is if anyone would like to come up, I'll show you a test we did in this study, and just to consider how you can stress maybe that area as well. And we've just had data for sort of, yeah, we just analyzed the data, but that's actually a little bit interesting. So if anyone could just come up, I'll show how that test is. It's a very quick test you can use. So if anyone is happy to come up.
Many volunteers in the back. And
So,
The natural born volunteer. An applause.
so it's a 45-second test. Basically what you do is you go into 60 degrees, put your leg backwards like this, and then you just have your finger, and then you
Please
just
move closer so everybody can see.
then you just stand there for 45 seconds. So just try to come closer here. 60 degrees. So normally we would use a goniometer. So you have to come a little further down, and then this leg. There you go. This leg goes opposite, and you hold it there. And then you just hold that for 45 seconds. And the idea is, he does it really well, is we want the quadriceps to be active. And because that leg goes there, he has to be active. So instead of just hanging like this, that a lot of people do, we want full load on that. Can you feel that here? And then he's just standing there. It's a very boring test, but it's very quick. So thank you very much. But then what we saw with that test was that on average, and then we asked them how painful is that. So as soon as they come off, how painful from 0 to 10 is that? Average for these patients is 5, and they would actually range quite a lot, but 5 is average. Control group, no pain, so that's good. But what is really interesting is when we then use this test across for every time they come in, and at the 12 month, and then relate that to the KOOS pain score, there is a correlation. So when you change on this test, get better, have less pain, you improve your KOOS score as well. The relation is not 1-to-1, so it's a 0.5 relation, but it's still something that reflects your clinical improvement. And usually when patients are not very good and have a lot of pain, this is quite painful to do this. So again, we use your 0 to 10, but in a very specific standardized function. So this is something you can go home and play around with, something that I played around with for a few years to see if we could make this work. And actually on 200 patients, it looks as if there could be something there that we could sort of more physically measure and provoke them. Again, I think we're pushing quite hard on the cartilage there.
It's the Thorborg test. And that's if you pull out the old papers about the pain monitoring model, you'll see that is one suggestion. Find a couple of exercises that the patient has problem with and use that as a guide or a evaluation over time. And if they have pain 5 here, first time, and they have 4.5 and 4, it's very reinforcing for the patient to see something is happening. I still have a lot of pain in my knee, but it seems to be going the right way, and that will strengthen them.
And what we saw was, if you remember, James did the test where he did the step-down test. So the step-down test has been used a lot. What I've found with the step-down test is, and I can show this quite good because I actually have some patellofemoral problems on the other side here. So when you come down, like this, when you come down here on this leg, and if you have a patellofemoral problem, you do this straight away to offload this area. So he was talking about the stability up here, but if you don't want to load this here, you don't want to load it, don't want to come down there, people will drop down. So I think for many years we've been fooled by, and then you think, oh no, it's a core stability, you need to train up here, when probably you can't really take the load through the system. So for us it was, what we played around with was actually finding an activity we could standardize without getting this, without patients trying to trick us. Yeah.
I have 2 questions to Mats Lindberg. There are a few medications floating around. Are there any effects of those medications, like glucosamine or hyaluronic acid? That's the first question. And the other question is, why do you think why don't we do more osteotomies? As you say, they're so successful.
Yeah, the first question is glucosamine and hyaluronic acid. And those are mainly thought of to be used for osteoarthritic patients, and glucosamine has in studies shown to give equal results if you compare pain reducing effect like diclofenac, Voltaren. So it could be pain relief, but it's said to induce a growth of cartilage, and that has not really been proven. We did an experimental study where Sebastian Concaro, that I mentioned before, he made chondrocytes to become sick, and then he gave glucosamine to the sick chondrocytes, and then he compared it with healthy chondrocytes. And the healthy chondrocytes, they didn't want any glucosamine because they were having their own normal production, while the sick, diseased chondrocytes used it. So it might be something that could be beneficial, but it's also very long process before you could see anything happening. So people have to eat it for years. So I think if you have pain reduced effects, you could give it to some patient because it's harmless. It has no negative effect. Hyaluronic acid has to be injected into the joint, so it's more active treatment. And it was popular for a while in early osteoarthritis, and then it went down, but now there are new studies coming up. So it could also be something that we will see more in the future, but it's just a slight effect, so it's not a major effect. Regarding osteotomies, I think many operations that we do is influenced by popularity, and in this country it has not been so much discussion about osteotomy in the last year. Many years ago in Malmö, they did preventive osteotomies very early on, and that was a very good idea, maybe, even though it's a large operation, but they did it before patients started to develop severe pain. In England, for example, there have become an enormous interest in osteotomy, so they have done meetings twice a year with a lot of courses, and I think that's the way to maybe to influence the doctors to do more. And regarding ACL surgery, you could use osteotomy to stabilize the joint without doing ACL surgery in patients that have early osteoarthritis. So it's a very good operation, and I hope it will be something more used in Sweden as well in the future and in other countries.
We have one question here.
Very long, right? Right. I have a question for Mats. If we got ACL reconstructed knee, no big cartilage injuries or other injuries at all, we know that the cartilage still is weak for quite a long time after the reconstruction. And how much do you think that the progression of the rehabilitation by jumping and those kind of loads, how much does that mean in the long term? Do you have any thoughts on that by osteoarthritis point of view?
Yeah, I think that's an important question because rehabilitation for cartilage surgery is not so well studied so far. We need more people to do studies on how to rehabilitate those patients. But for example, I'm very aggressive in my weight bearing, so our patients are allowed full weight bearing directly after cartilage repair. So in order to do cartilage repair together with ACL surgery, you don't have to be worried. You could get them to bear as much weight as pain decides. So it's pain that decides, because all tissue need to have some load, otherwise they will not be developed in the right way. And for many techniques like microfracturing, the patients are not allowed to bear much weight, or in the beginning not any weight at all. So I think that's very important. The other parts like jumping, etc., we don't really know exactly. But for example, if you have a lesion in the trochlea area, you have to be different in your mobilization when if you have a lesion in the femoral condyles or tibial plateau. But exactly, this is difficult to know, but as we've heard about the weight bearing characteristics of the patellofemoral joint, the same is of importance when you're treating the cartilage repair. But it's important that you are not too afraid. It's better to have weight bearing that are non-weight bearing. That's for sure. That's the only thing that we know. But the way to do the rest of the exercises is very difficult, and we need more of you to do studies on that.
Roland wants to say a word.
Yes, follow-up question, almost similar, because there is a debate among patients and physios if there are exercises like jumping and running, high-loading exercises, that if the physio monitors pain and swelling and symptoms very, very carefully, is it possible still that you can get damage to your knee or the cartilage without knowing it, without getting any symptoms over for months or years?
For local cartilage defects, the most dangerous thing is that you have shearing forces, rotational forces. So those are the forces that you should avoid in the beginning, because even normal cartilage sustain easy injuries when you have rotational forces. And I'm very afraid of, especially when you have trochlear lesion for I don't know the English word for impulse training, because that's very fast movement that could be detrimental, because if the patient is still a little weak, there could be a degree of rotational forces in the patella that could have a negative effect on the repair tissue.
That sounds like an acute pain reaction then. If you do it and you don't experience any pain, and you progress further to sports activities, no pain, no swelling, can you still be having damage to your cartilage?
Well, because the cartilage itself has no nerve supply, so in that sense we are depending on the surrounding tissue to give information about the situation. And as we don't really know exactly, we should avoid that, because we should think which situation could you have too fast rotation. If the rotation is slow, the patient could, if the muscles are enough strong, balance that reaction. But that's why it's so important that patients not are training themselves too much in the beginning. They need really the expertise from the coach, the physiotherapist, to tell, now you're doing this way very slowly, and you're not allowed to increase beyond that level, etc., etc.
I would just like to add, because that makes a lot of sense in my head as well. As a physiotherapist, I think I really like controlled strength training, even in machines. And for one of the reasons I really like it is not because people have muscle deficits. I think as physios, we are very often very concerned with muscle deficits. The reason why I like it is exactly for what Mats is saying, is that you can control peak loads, you can control that you don't get these rotational loads in the beginning, and it's much, much easier to control. As soon as you have your patient on one leg and even get them to balance, you have all loads going on at the same time without knowing what's going on. So I think strength training for me is just a very, very good way of getting them loaded up in a much more controlled way. And of course, I would like them to get stronger in the muscles as well. But when you do really heavy training, we tend to forget that when the muscles are really, really active, there are also really, really a lot of stress on the other tissues.
Yeah, and taken together that jumping and running, you suddenly increase the forces to the body by twice the body weight, 3 times, 5 times, 10 times the body weight. In controlled strength training, you never reach those forces. So I agree. But it's very difficult to monitor the decrease. That's why return to sport is so difficult, because suddenly there is such an increase in forces.
Now this is getting interesting, isn't it? So if we go back to the patient who sustains an isolated ACL tear, there's usually a little bruise or something to the cartilage as well. Sometimes also an associated subchondral bone marrow edema, which we know can sit there for 2 years before it heals out. Do we need to think about this in rehabilitation? Is it okay to start running and jumping 3 months after reconstruction?
With the subchondral edema?
Well, that is also something that we don't exactly know. When we started to do chondrocyte implantation, we said that the patients are not allowed to run until 7 months, circa 7 months. And some patients didn't follow the instructions and went back to football, for example, at 6 months, and they had new problems very fast. So we are very slow in that going back to sport, because the maturation of a repair tissue is extremely slow, and that's why many of the professional high elite football players and other athletes do not want to do cartilage repair, because they will not have the time, and the clubs will not allow them to go back to sport. So we are in a little ethical issue then, how to do them with the patients. So some patients, they suggest that and ask the doctor, give me something to keep me going another 3 years, and then I could do the cartilage repair. And so it's difficult that way. An ACL surgery also certainly takes a long time for them to go back to, but the cartilage is more difficult and takes longer time. So especially for a normal person, 1 year could be enough to do sport, but to have high demands, you have to have better durability of the repair. It's not longer time. So that's why it's very difficult to advise what type of treatment to do, and that's why many patients are operated on microfracturing. And as I said before, a plug like a mosaic plug that could be healed by bone healing after 3 months, that could be the solution for a sportsman to go back to sport earlier, maybe. But otherwise, most of them are waiting because of this problem.
And if I try to get a clinical perspective on that, is I think again, if you're being an experienced physio, or if you're used to seeing how people move, I think one of the things you should really train yourself to is also to see when your patients are offloading, because we are, as physios, we often tend to see offloading as a problem, and we want them to load more. But sometimes I think this is the body's way of telling us, don't put more load on now. This is, I will do a little bit more on my left when I do the squat, because this is the load I can take at 5 months, maybe when you do the. Whereas we as physios tend to push them over on that leg and say, no, you need to train that leg, because otherwise you won't get strong enough. But it could be that your underlying cartilage is not ready for more than leaning a little bit to the other side. So I don't have any tests to prove that. Just when you look at it, be careful not to think that everything is movement dysfunction. Some of these ways is the body's way of trying to move around the problem, so to say, in my opinion and my experience. And it's just trying to give you a different perspective. And you see it very, very clearly when you get patients from guys like Mats, when the strategies they do to not load their cartilage, especially in the beginning. If you see how they walk, when they get off the crutches, a lot of what they're doing is trying not to activate the quadriceps, because as soon as they really activate the quadriceps, they increase the loading on the bone, on the cartilage. So of course we want the quadriceps to work, but you also have to understand that that will also increase the pressure on the underlying tissue.
Now looking into the future, as I've shown you a couple times before, we developed the visual analog scale further into an app that you can have on your phone. So I can ask the patient, sit there, and I can register the pain, and I get a reading of 5.2, and then I can click and I can feel it in my knee. It's tremendous. And then we can communicate. I can say that's nothing. And also we did further development. I can mail this sensation to Mats and ask him, what do you think about this? And he can put it to his knee, and he can say, it's okay. And then I can when the patient comes back in 3 months, this is what you felt 3 months ago. And this is what you have today. It's very good. And the very best thing, Mats, with this app is that we have a tissue healing sensor. So I can get a perfect reading of the healing of the cartilage in % compared to the healthy side. It's now available. You can download it. It's on Android and Apple. It's no problem. It costs $200. It goes directly to my account.
Very good. I'll tell you a funny story about thinking that you can measure something in your knee with, and this is a real story, not a, and this was actually my supervisor, Eva Roos, and I think maybe Roland knows this story, but she was supposed to, and if you think about how we try to measure in the studies I just showed you as well, Eva was developing the cool score, and before that she was using a VAS scale in relation to the knee, and she gets this lady, an older lady in, and she's asking her, so and she has the piece of paper on a scale from 0 to 100, could you put how much does your knee hurt? And the patient actually takes the piece of paper and puts it over her knee, like Roland just did, and then she looks at Eva and says, how the hell am I supposed to measure how my knee is feeling with this piece of paper? And And Eva thought, that's the end of that scale, so I'm not going to use that anymore.
I think that sums up quite a bit. And the first thing I'm going to do now is that we're going to thank the speakers that are still here. With a great applause. And you will receive a book about return to play in football. Susanne, I have one for you as well. So please come forward. We've had two great days. We've discussed a lot. There's so much more to discuss. So we will have another congress course next year, of course. But most importantly, the ones we have to thank is all of you for coming and sharing thoughts and ideas and discussing throughout the course. So, a final applaud to yourselves, and I hope to see you all next year. And there is a certificate for everybody outside, so please grab that before you leave. And I think the speaker will answer a question or two if you want to.